see you all tonight. Finally got the kids down to bed. For those of you who are studying for the KFP, oh my goodness, you have my complete admiration as well. And those like me who are trying to do this while having kids and working and having a family, it's a load. So hopefully you are all ready to smash some KFP questions tonight, as well as have a bit of an overview as to where we're at now, only a couple of weeks away from the exam. If you want to say hello, say it into the chat. Feel free to put any comments, queries, answers in the chat or comments below, and I'll comment as we go along. So without further ado, let's get into the content for tonight. And first thing we want to say is, well, that's not what we want to be seeing. Let me fix that up there, so that you can actually see there. So once again, tonight is sponsored by me, which doesn't really mean anything at all other than I've put this together. If you're going to find this helpful at all, please just let me know by putting it into a subscription form so that I know to make these things ongoing. So again, to reinforce, we've had a format change. Oh man. You ever have those days where things don't quite go according to plan, where life just seems to be not quite what you thought it was going to be? Tonight for me is one of those, but that is okay, we are getting there. Let me just make sure I've got the right presentation up, and away we go. So we do have a format change for the exam. We do know this is going to be a written exam, so if you're not practicing already, please try and practice with written questions, written answers on paper with pens, black pens, so that you're doing it as close to the real exam format as possible, making sure that you're going to give your responses in a way that you would be doing on the actual exam day. For those who have been practicing so far with computers, now is the time to make that transition, to make sure that you're doing things in a way that you would be on the day, and you're not going to catch yourself short or potentially muck yourself up by not being able to write for such an extended period of time. So again, the college has released not one but 2 practice exams. They're only half exams, so just 13 questions each. So this would be a perfect opportunity for you to try and print them both out, do them back to back, and it is self-marked. And again, I would encourage you to actually get someone who isn't you, who preferably has done the exams and passed them, to mark the exam for you, to make sure that you're answering these questions in a way that you should be. Now, we do also have, for those who would be interested, a special tool made to try and help people prepare for the exam, a KFP case generator. I know that one thing a lot of people ask about is, where can I find more practice questions without having to necessarily pay for all these additional services? And this is why the screen was mucked up before, because I had it set up on this other screen. Let me bring it up here. So on the website Generally Practicing, which is just at generallypracticing.com, there is a KFP case generator. I would encourage you to, if you're seeing interesting patients through the day, to pop some of the details into here, where you can just insert, for example, say you've got a 44-year-old female who presents with, let's say, several days of chest pain, shortness of breath, and let's say rhinorrhea. Let's say it's something completely random, because let's be honest, that's how they turn up in real life. You can submit this, and all this does is, from your prompt, generate 3 specific KFP-style questions to get you thinking along this, and you'd be amazed how just practicing this every day for a couple of cases that you randomly select from the patients you've seen, how you not only realise there's a lot more you potentially could be covering for the patients, but also to know that you're answering things in a way that the KFP wants you to answer them in. All right. Hopefully that's useful for some of you out there. Moving on then, let's go to our first set of questions for tonight. We'll put, as always, 2 minutes on the clock. You will likely have more time than that to do the questions in real life, but we want to be practicing on a bit of a time crunch so that we're ready for when it's actually time to sit the exam. Your time starts now. Luna Chen is a 27-year-old female librarian who attends your GP clinic complaining of 48 hours of left eye pain and redness. She describes no preceding injury, with slowly progressive ache and burning sensation to the left eye. She has a history of mild lower back pain that she takes infrequent ibuprofen for and takes no other regular medications. She is a non-smoker and drinks 3 drinks of alcohol 3 nights per week. Her heart rate is 82 beats per minute, blood pressure 118 on 81, her respiratory rate is 12, and her BMI is 22.7. What additional aspects of history would help in developing differential diagnoses? List 5 specific additional aspects of history. All right. Now, hopefully you've all had a couple of ideas put forward from here. I think this is a relatively good question for KFP because it starts off by asking you what are your differential diagnoses, and probably more applicable here is what things lead you to each of those diagnoses. So, of course, we have the dreaded unilateral red eye question. I think this is something that we potentially will see in actual exams. And again, to highlight my exam technique, underlining the relevant details to this question, and in particular when we get to the question itself, focusing in on what is the question being asked. So additional aspects of history in developing differential diagnoses, and listing 5. So I'm starting off by listing out 5 things to make sure that I'm actually going to be answering the question asked, no more, no less. Let's have a look at some of the answers here. So, any case of unilateral red eye, there's a pretty handy framework through RACGP checks and some previous papers through Australian Family Physician. Of course, one of the big things you're going to want to know is, has there been any changes to visual acuities? This could be blurring, diplopia, flashes, floaters, things like that. Anything that's going to change the way the eye is actually seeing. Now, any of those things I think would score you a mark. And I think for this situation, you're probably better off listing one of those things. So, for example, has she noticed any blurring of her vision, or has she noticed any diplopia or double vision? And I would stick to that kind of response. These kinds of things are more answer cues for the assessor's marking to know what kind of things to be looking out for. So again, we'd be wanting to keep it nice and concise, nice and specific, and avoiding any overcoding. So I wouldn't be listing all of those things there. I'd probably just stick to one. Now, different to that would be, has she experienced any photophobia, as we're starting to think of some of our more sinister causes, and has she experienced any discharge from the eye? We're going to have slightly different thoughts of what could be going on if there's things coming out of the eye as opposed to things not. Is the eye itchy? Again, kind of leading into a bit of that kind of atopy kind of area. And was there any preceding activities that may have contributed? Now, they have specifically said there was no preceding injury, but that is not quite the same thing as any particular exposure, and that could be something that brings out, say, a pollen exposure, and again highlighting the atopy, or of course the dreaded grinding, because there's always some kind of construction work or grinding that occurs, and there's a foreign body there for sure. Now, of course, if you're not so comfortable putting something like that down, you could then ask, is there anything like a family history of eye disease or conditions? And I probably would list something to specify down what I'm talking about there. So that would be something like glaucoma, uveitis, or in particular, any autoimmune disorders. Hint, hint, wink, wink, nudge, nudge. We'll come back to that later on. So hopefully you all had some good things on there. If you came up with something different, pop it down in the comments or the chat, and we'll talk about it as we go along. But, of course, that's not why you're here tonight. You are here to keep practicing questions. So without further ado, we'll put another 2 minutes on the clock, and let's bring back the questions. You examine Luna's eye, shown below. She complains the slit lamp light hurts her eye. What features of the eye exam confirm your suspected diagnosis? List 4 features of the eye. Now, of course, that is a little bit small, so I'm going to bring up a larger version just as a bit of advice. Yeah, it does look a bit creepy. All right, as time runs out on the clock, let's bring up some of our suggested answers here. And so, a question like this, where it's giving you that little bit more information, but then asking you that extra question, this is one of the ways in which the exam shows a consultant level of knowledge. So this is presuming from this picture you've worked out what the diagnosis is, and of course this is a case of uveitis. And so Demir, fantastic conjunctival injection and irregular pupil, absolutely nailed it. And they're obviously the very prominent things. Of course, if you really wanted to kind of get that extra little bit of points, you could specify that it increases towards the limbus, which is that little layer around the pupil where we switch, and you can actually see that faint kind of halo. Let's just go back for a second. We can actually see it is this layer around here, and yeah, Kane, fantastic job drawing red markers on a red eye. Good one. But that is the area we're talking about. And that's specific to this condition as well, being anterior uveitis, acute anterior uveitis. Now, keratic precipitates on the cornea. Again, if we duck back here, that's these little dots we can see over the top here. Again, this is something that's very, very common for this condition. Not always seen, but if it is there, it's one of those kind of pathognomonic kind of indicators. Impaired reactivity to light, as again the pupil becomes tethered, and that irregularity of the pupil is due to catching of the lens on the iris itself. And as it tethers down, as it tries to move about or constrict, that tethering kind of pulls it, and you end up with a regular border to the pupil. And with that, you can see impaired reactivity to light or meiosis. With that also comes decreased visual acuity, although, to be honest, I've just realised that one doesn't really apply to this because we're specifically talking about findings on this picture. So I don't think that one would be applicable, but you would expect that to be a finding clinically. Meiosis or constriction compared to the unaffected pupil. One of the ways it tries to protect itself is to constrict, and we do get that meiosis there. All right, so we'll say 5 potential answers here. And of course, there are a few other ones there that can be seen, but these are the key ones that I think you would pick up from this kind of picture. How did you go? Let me know. And of course, we still have part 3 for this question. So without further ado, let's put 2 minutes on the clock. And your time starts now. The examination confirms your suspected diagnosis. What is the most appropriate specific immediate management action? Write 4 specific immediate management actions. And I might just update this to 1. Cutting it early because, guys, let's just say the chat has it. This one is, of course, going to need urgent review with an ophthalmologist. So excellent job to Samir, excellent job to Demir. Now, I'm going to be a little bit mean to Demir, sorry, and just to go on about the specificity of answering questions for the KFP. And so, if we're saying urgent referral for ophthalmological review, there's a couple of ways that could be interpreted. And so, to really nail down the specificity, I probably would specify ophthalmologist, because ophthalmological review could just mean, say, sent to ED for a slit lamp examination, which is one of the reasons why I think you probably still would get the marks, but you would probably want to just be that little bit more careful and specify that it is with ophthalmology. Now, one of the key reasons for this is that you need to actually confirm the diagnosis before you start specific treatments, and you're really wanting to exclude things like endophthalmitis, and check the intraocular pressures before starting things like topical steroids, which would be the mainstay treatment for anterior uveitis. You would also be wanting to consider things like having them try and disrupt the tethering of the pupil to actually restore vision. Now, other things that you could answer would be referral to ophthalmology, which would still get you 1 mark. But again, if we're really trying to narrow down the specificity here, we should be specifying that we know and acknowledge this is an urgent condition. And so without specifying how quickly they need to be seen, you would lose a mark there. Likewise, referral to ED, you might still get a mark. You'd probably be playing it a little bit too risky there. And so I would be always specifying why you're sending them. Now, if you were to try and initiate topical steroids on your own without being able to differentiate those things, I think you wouldn't be awarded any marks. And likewise, any other answer in this kind of setting, really you need to be sending through and acknowledging the urgency of this situation. All right. So well done, guys. Now, something that I think's handy to think about anytime you see practice questions is ask yourself, what if we change this a little bit? What would be the things I'd be looking out for? So in this situation, I'd be wanting to know, was there any relevance to the history of back pain? And if you think you know something that would tie the two together, pop it down in the chat or comments below, and I'll post some comments myself. And of course, ask as well, what other conditions can cause irregularity of the pupil? What kind of things would you be thinking of in a slightly different story if, say, there wasn't those same symptoms, but still the irregularity there? All right. Now, of course, we have more questions to go, so let's throw another 2 minutes up on the clock. Your time starts now. So Amelia Kowalski is a 38-year-old female photographer who attends your GP clinic complaining of a 1-week history of facial pain and nasal blockage. Her symptoms began with a recent change in weather. She states she often gets this at a particular time of year. She has no other significant medical history and takes no regular medications. She's a non-smoker, but her boyfriend who she lives with smokes 10 cigarettes a day. She doesn't drink alcohol and denies any recreational drugs. COVID has been definitively excluded. Her heart rate is 67, blood pressure 121 on 81, her respiratory rate is 14, and her BMI is 25.7. What aspects of history would indicate a serious cause of her symptoms? List 4 additional aspects of history. All right, so let's have a look here. Now, this is a question that in particular is worth paying attention to because they specify things like boyfriend she lives with smokes 10 cigarettes per day. That's always something I think it's worth filing in the back of your mind because there is so little space and time in this exam to put down information. And so you have to presume usually every detail they give you is noteworthy in some way, shape or form. Pardon me. So let's have a look through some of my answers again. You probably noticed I would go through and write down 1, 2, 3, 4, making sure I'm answering the exact number of questions that are being asked. So we've got a couple of awesome things in here. So severe headache, fantastic, as well as fever, weight loss, very good. Now, acute onset of confusion or impaired consciousness is an absolutely extreme example for something in this kind of a setting, but would be something that would have you considering a more sinister cause, and that would be, of course, if the infection had actually turned deeper and was turning into more of a meningitic type picture. Likewise, diplopia or impaired vision can be early markers. Other signs of meningism such as neck stiffness, severe headache or photophobia. Periorbital edema or cellulitis, again acknowledging that we've got those symptoms there of the facial pain and full sensation. Could this actually be an ocular presentation? Proptosis, again, going down eye presentation. Epistaxis, being that migration through the nasal passage into deeper tissues. Persisting fever of 39 degrees or higher. Again, indicating more severity of illness and other signs of sepsis or septic shock. And in that, I would be including things like fever, as you've put there, and potentially headache as well. Now, with the headache response, I again would probably specify severe headache, as you know, this from the history alone sounding very much like a sinusitis type presentation, and so we want to be specifying that if we're thinking a serious cause, we should be looking at severe headache. So very well done there. All right, let's go on for another question then. If you are ready, we'll get another 2 minutes on the clock, and your time starts now. Thankfully, she has none of those features, but did experience a fever of 38 degrees for a day or two when symptoms began resolving quickly. Regardless, she's keen to speed up her recovery, as she's finding her symptoms frustrating while working. What management options are appropriate for her presentation? List 4 management options. Dosing is not required. right, so let's have a look at some of the answers. Again, I want to point out here that something that's relatively new in the scheme of these exams, and that is the fact that they are specifying that dosing is not required. So we presume, unless specifically requested, dosing will not be an element of the KFP exams. And there's been some hints from discussions with educators and the authors of the exam papers that it is very unlikely that any dosing will be required at all. Certainly if you've done some of the practice exams already, you will have noticed that is the case. And again, something that you'll probably see time and time again is, of course, this line up here, that COVID has definitely been excluded. For some reason, they really want to emphasise that these exams aren't going to have anything to do with COVID, and I think that also reflects just the body of knowledge on COVID at the moment is probably evolving too rapidly for writing exam questions in a safe way around that topic for now. Of course, probably fair game in the future, so still something we want to keep on top of. So, answers and some excellent ones coming through. So, steam inhalation, paracetamol, pseudoephedrine, nasal spray, avoiding passive smoke exposure. Again, if I'm going to be super duper picky, the steam inhalation on its own isn't or wasn't listed in any of the marking rubrics I could find, and certainly in the checks and papers wasn't a part of it. Rather, things like saline irrigation, so your Fest sinus rinse or sinus sprays are recommended, not so much just direct steam inhalation, which doesn't have deeper penetration. But simple analgesia, spot on. Likewise, pseudoephedrine nasal spray for uncomplicated sinusitis isn't actually recommended at the moment. Instead, it's preferred to try things like intranasal corticosteroids or intranasal decongestants or ipratropium bromide in first instance. The ipratropium bromide as well, there's a bit of an atopic kind of component to it. Now, avoiding passive smoking exposure, absolutely nailed it. Again, going back to that information I gave in a STEM for free marks is acknowledging that the boyfriend does smoke and that smoke exposure is likely to exacerbate sinusitis. Now, some other answers put forward here would be oral antibiotics. Now, for uncomplicated, likely viral or atopic antibiotics are not recommended in first instance. If we were to, say, end up with a change, if symptoms worsened, if fevers had returned, if there was more of a purulent discharge from the nose, that or erythema or warmth over the sinuses, that would be, I think, when we're thinking more of that bacterial component, and then antibiotics would be indicated. But absolutely nailing it with saline nasal wash, nasal antihistamine spray, and boyfriend smoking cessation. Excellent. Of course, we can't say replace the boyfriend, but sometimes we're probably thinking it in the back of our head. Anyway, moving on. So I think the only one we haven't really talked about would be oral corticosteroids wouldn't be worth marks in this one, and antihistamines, which is an answer that often does pop up for these kinds of questions, doesn't actually have a lot of evidence behind it. And so while it is still common practice and probably not the best practice, there's no real evidence for efficacy behind it. If we're trying to show that consultant level knowledge, you wouldn't be awarded the mark here. All right, so let's move along. We, of course, still have one more question to go. We'll pop 2 minutes on the clock, and your time starts now. So she makes a full recovery. She comes to see you 3 months later in tears, stating her boyfriend and her had broken up as she found out he was cheating on her with a mutual friend. She requests a sexually transmitted infection screen as she feels she doesn't know if she could have caught anything. Her and her boyfriend always use condoms and she is currently asymptomatic. You have no record of any previous investigations, and she states it has been years since she had any pathology other than her last CST performed 2 years ago. What screening would be appropriate to perform for Amelia? List 4 specific screening tests. All right, so some great answers coming through. So for this kind of question, and this is a type of question that does come up fairly frequently in these exams, would be making sure that you've got a decent understanding of up-to-date STI guidelines. And for this, I would recommend using STI Guidelines Australia. So we've got a couple of answers that have come through here, and 100% correct in terms of urine chlamydia PCR, urine gonorrhea PCR, HIV serology is recommended for, and syphilis serology. They're 4 things that are recommended in all STI screens. Interestingly, we have specified that she is asymptomatic, and so in the guidelines currently, if you're asymptomatic, things like hepatitis C is not actually recommended as part of routine testing, so would be one that we wouldn't be having. Now, what would change that, for example, would be if she's living with HIV, if there's been any HIV pre-exposure prophylaxis use, any injecting drug use, anal sex with a partner with hepatitis C, incarceration, non-professional tattoos or body piercings, or receipt of organs or blood products before 1990. Now, I did have to read those off a prompt card that I'd made earlier because there's a rather set guideline there, but some things to keep in mind. Now, trichomonas would be screened in at-risk populations, but wouldn't be applicable without further information from this STEM. And things like screening for bacterial vaginosis is not recommended, or HPV is not recommended outside of any asymptomatic when you have otherwise recent cervical screening test. So we also have some awesome answers coming through. Well done, Samia. Absolutely nailed it, guys. You have done very well indeed. So hopefully you have found some of these questions helpful tonight. I'm planning on, in the next couple of days, putting together a summary of kind of an approach to answering exam questions, how to keep it concise, how to keep it as relevant to the questions being asked, and again, kind of outlining my approach to answering these questions to speed up the information transfer for getting some of that information out there. So if, again, you found any of these helpful, please consider subscribing if you haven't already. If you have any questions, comments, queries, pop it into the chat or comments below, and I keep an eye on it and check it every single day. So we'll get back to you as quick as possible. Now, I do want to point out that one of the questions asked earlier on was, is there any relationship to the back pain and anterior uveitis? And Samia absolutely nailing it there with acute uveitis relating to ankylosing spondylitis, HLA-B27 positive. So there is a known strong association between ankylosing spondylitis and acute uveitis risk there. And so would be something I would be considering screening for further on once we've sorted out the anterior uveitis, though, to say, hey, guess what? The good news doesn't stop here. We've got a bit more work to do. And again, that kind of thinking, as you've done perfectly, reflects as well that you have that kind of consultant level knowledge that's showing that your clinical knowledge is where it needs to be. Let's keep tackling that and smashing this exam. Now, ultimately, again, this is an exam that is as much about answering the question in the way that they want as opposed to just getting the answers right. And so do practice writing out your responses to questions every single day as best as you can. Feel free to use that KFP question generator. And of course, come back next week where we'll have even more questions loaded up with hopefully fewer technical issues than we did tonight. Again, looking forward to hearing from you and seeing you there 8:30 next Wednesday. Less than a month from the exams, so head down, bum up, we'll get through this together. Thanks for joining me tonight. Good night.